Hello, my name is Fraser By, and I'm a PhD student studying tissue engineering of the cleft palate. So, what is a cleft palate? It's an abnormality in the maxilla. This is the bone found at the roof of the mouth, and it affects between 1 and 5 to 700 worldwide. The symptoms of cleft palate are the child cannot suckle. Without a hard palate to push against, you can't suck. Also, without that hard palate, there's poor speech development. The hard palate is instrumental in the formation of sounds for quite a lot of letters, including things like G and K and D. As the mouth and nose are connected to the ears through the eustachian tube, having a cleft palate opens this region up and also leads it to increased chance of infection, which can be quite painful. Also, if left untreated, you have the psychological impact to consider, and when the child reaches school age, this is considerable. It's currently managed through the use of squeezy bottles, so this negates the need for the child to have to suck. The parent can literally squeeze the bottle and feed the child. Also, a prosthesis known as an obturator can be used, and this is fitted to the roof of the mouth and gives a hard palate for the child to push against. The problem with this, though, is it has to be made for each individual patient, and also, due to the rate of growth of the child, it perhaps will only last 3 weeks before it needs to be changed. Here we have the current NHS treatment timeline. From 0 onwards, an obturator must be used. At 3 months, a lip repair is performed. Between 6 and 12 months, the hole in the hard palate is covered with soft tissues. Between 1.5 and 5 years, there's ongoing speech assessments and therapy. And from 2 to 15 years, there's ongoing orthodontics. And at 9 years, you get the only bone grafting you will see, or a cleft palate patient will see, and this is a bone graft to the alveolar ridge. The alveolar ridge is this part of the skull here, right at the front. And it's worth noting that the palate is back here. So this bone graft doesn't touch the hard palate, and in fact a cleft patient will go throughout their life with a hole in the hard palate. It will be covered over by soft tissue, but this will be floppy. There's nothing hard there to push against. So the flaws of the current treatments are as follows. No hard tissues are replaced at all. Invasion of fast-growing soft tissues into the region where you want bone is a huge problem. Should we try and put anything in this region, we're going to get invasion of soft tissue because it grows that much faster than the bone trying to grow in. Aside from this, we've got the rate of the growth of the child. So while we're trying to repair the defect, we've got to account for the fact that these palatial shelves are moving apart. So why not do a bone graft here? When it has been tried, we think due to the formation of scar tissue and contraction in this region, there's major disfigurement. And it has been reported that when people have tried bone grafts, the outcomes are worse than not actually operating at all. So this is unacceptable. To show you just how fast a child grows, this is a measurement of head circumference with age. Between the ages of 0 and 5, the growth is exponential, and in this schematic you can see just how much the child's jaw drops down and moves out as it grows into an adult. This is our ideal treatment timeline. From 0 onwards, we're going to need to use an obturator. Unfortunately, children have an amazing propensity to put things in their mouths that they shouldn't, and we can't risk something like a pencil puncturing what we put in there. From 3 months to a year, we intend to do a complete lip and cleft palate repair. This would provide as normal a life as possible. From the ages of 2 to 15, we propose to do the ongoing orthodontics still. Unfortunately, teeth are teeth and they need to be repaired, and our operation won't be able to cover that. But as you can see, we intend to remove a lot of other operations which would otherwise cause aggro and stress to the patient. In order to do this, we are going to need something which promotes the growth of the soft palate. The region that we're going to repair needs to have a protective barrier, and the best thing for this are the tissues that already exist in your mouth. So we want this to be able to grow over whatever we put in there. The thing we put in there needs to encourage bone to grow, whether that's bone growing in from the sides or spawning in the centre. And finally, we need something which is going to prevent soft tissues from invading. Otherwise they will just completely dominate and fill the space. And finally, whatever we put in this region must allow for expansion due to the rate of growth of the child. So to do this we propose to make a membrane that can stop cells from penetrating, but allow nutrients to flow through, so that if there is bone growing in here it can proliferate. We don't want to remove whatever we put in there, so it must be biodegradable and biocompatible. Also, as the child is growing, it must deform as the child grows, and there must be a distinction made. It cannot be an elastic material because this would put stress on the area and cause contraction and disfigurement. So it has to be a plastic distension. So everyone knows what elastic distension is. They get an elastic band, they stretch it, release it, it shrinks back to its normal size. A plastic distension is what happens when you stretch something like a carrier bag. You pull it, it stretches, and it stays in the position it's been stretched to. The two polymers that we are going to use to do this are polylactic acid and polyhydroxybutyrate cohydroxyvalerate. These are both well known as biodegradable polymers. You find PHBV in most supermarket carrier bags. It degrades in around 6 months to a year. We're going to process them using a technique called electrospinning, where you take a charged polymer solution and an earth rotating drum. The positive charged solution is attracted to the earth drum, it's drawn out as a fine fibre, whips round for a bit, the solvent evaporates off and it's deposited as a fine fibre on the drum. Here's an electrospinning rig in the wild. Here we can see a crocodile clip connecting it to a high voltage power supply, the polymer solution and the rotating drum. So when we electrospin PHBV, we get a network like this. And okay, there's some quite large globules, but there's also a lot of these very fine fibres, and these are about 300 to 500 nanometers in diameter, so they're very, very small. It's also quite a dense network, and if you think your average cell is 20 microns wide, and looking around here, the largest hole is perhaps a couple of microns, there's no way that a cell's going to squeeze through here, so this is just what we want. So this will provide an excellent barrier. However, we want things to grow on the other side, so we want something that cells can migrate through and proliferate in. This is the PLA. These fibres are much bigger, perhaps the order of a micron, and also there's much bigger holes, about the order of 20 microns. Great for a cell. So this is just what we want again. So, if you electrospin PHBV, you get a really dense layer, which is great for a barrier, and then you can electrospin PLA, which is great for cell growth. Now, this is the bilayer here. You can see that the PLA is a lot thicker layer than the PHBV. This is the same amount of polymer, just the PLA is much fluffier and it occupies a much greater amount of volume and space. So it just goes to show how dense this PHBV layer is. So, does it stop cells? In our experiments so far, it does. To test this, we've taken some cells, we've dyed one set red, dyed another set green, put them on the scaffold here in blue. We put the scaffold in an open bottom bucket, so this is just to prevent cells from crawling around the outside. This means that the only way the cell can go, if it's going to go anywhere, is to burrow through. We then left it for 24 hours and then came back and looked to see what happened with the cells, and here are the results. So this is looking at the side we see the green cells. Here you can see there's plenty of green cells dotted all over the place, and then we can look for red cells. There aren't any. There's kind of this faint, vague red fluorescence of something lurking beneath, but it hasn't quite come through. So this is a success. Likewise, when we take it, turn it over, and look at the red cells, okay, they're a little bit faint. Here's one. There are quite a lot of them around here, all over the surface. And then we look for green cells. There isn't any cells like we saw on the previous page, no really bright ones, but there is this kind of vague green fluorescence of cells lurking beneath. Here's one popping his head through, but he hasn't quite made it. So this is also a success. Taking a cross section, in blue we have the PHBV layer here. You can see on one side we have the green cells, on the other side we have this halo of the red cells. There's no green cells on the red side, no red cells on the green side, so this is a success. So, the problem of cleft palate is twofold. First, we need a barrier to prevent the invasion of fast-growing tissues to give the bone a chance to grow. We've got that. Secondly, we need to be able to cope with the growth of the child, and this is a bit of a problem because we've got lots of things for testing things in one dimension, so up and down. However, the palate we can treat as a flat surface, and so this is two-dimensional, so we need something which is going to expand in both the x and y axes. When you do the maths, the worst kind of defect that you can hope for, or the change in the defect, is going to be a doubling in surface area. So the membrane must be able to cope with this kind of growth. So how are we going to do that? We're going to make a wrinkly scaffold. So here we have the PHBV layer and the PLA layer. We make the PHBV layer all crinkled up, and so when the child grows, it can unfold and unfurl and cope with that distension. That's all very well, but how do you make that flexible surface? So we take a balloon, you inflate it so it's twice the surface area that you required the scaffold to be, and then you electrospin onto it. Here's one side that I've already coated. The balloon's filled with an electrolyte. This makes it a good conductor, so it can be earthed and electrospun onto quite well. Once you've coated the balloon in your PHBV layer, you can then deflate the balloon to the surface area required, and it's at this point that it all becomes crinkled up. You can then coat it in a cell-friendly layer of PLA. That's nice and fluffy. And here's the finished product. So you can see the balloon is completely white and coated in scaffold. This was a red balloon, so you can see we've got excellent coverage here. So this is good. Now we need to take it and test it with cells and see how cells perform. How are we going to do that? Simple. Just put cells straight on the balloon. And feed them, water them, keep them at 37 degrees or thereabouts. So here I have a balloon in a bottle. Here's the balloon, and it's got cells on, and as I said, it's fed and watered. I've also connected the balloon to a syringe pump filled with water, and once I've given the cells a chance to move in and make themselves at home and put their feet up, I'm then going to make them work by turning on the syringe pump and filling the balloon with water. This will make the balloon stretch and make the cells do some work, and I shall see how they perform. This is where my research is at. I don't know the results, but I look forward to presenting them to you in the future. So, in summary, the cleft palate is a complicated twofold problem. First, you've got to be able to create a bilayer membrane that will stop cells from proliferating through it, but allow stuff to grow on the inside. And finally, we also need to create a membrane that can cope with the biaxial distension as the child grows, and that change in the cleft palate. And we've created a biaxial distension rig to test this, and we've also created a wrinkly scaffold which we hope can cope with the growth of the child. I'd like to thank you all for listening, and I'd like to thank everyone at the Croto Institute and the University of Sheffield and for all their help and support during my PhD. Thank you very much.